our group had cryotherapy research article analysis, our article being called "Should ICE application be replaced with neurocryostimulation for the treatment of acute lateral ankle sprains, a randomized controlled trial?"
So for our background, ankle sprains make up 1/4 of all musculoskeletal injuries, and half of those are sports related. And from those, 20 to 50% of these can lead to chronic pain or chronic ankle instability. And using the widely used RICE protocols, which is known as rest, ice, compression, and elevation, has been found to have weak evidence base for meaningful clinical and functional improvements that mostly relies on low quality and inconsistent studies. Systematic reviews show stronger evidence for early mobilization, analgesics, braces, and manual therapy. And while cryotherapy provides short-term pain relief, it shows inconsistent benefits for function and swelling, showing limited additional benefits when paired with exercise. However, there is no final consensus on what the best protocol is or application is. And this specific study explores the neurocryostimulation, also known as CNS, to be a better alternative to ice, which improves a rapid cooling effect of the skin from alternative to ice, using the pressurized CO2 to reduce edema, analgesia, and inflammation while promoting vasomotor effects and muscle relaxation. However, the proposed benefits from CNS remain speculative due to the limited studies that it has, using its experimental design flaws and weak application protocols.
As the title suggested, the objective of this randomized control trial was to compare the neurocryostimulation treatment of acute lateral ankle sprains to traditional ice application, trying to see which is better for reducing pain and edema and which improves functional recovery, including ankle dorsiflexion range of motion.
So there were 41 participants included in this study. They were chosen using the following criteria. So they all had a moderate to high grade acute lateral ankle sprain within the last 72 hours. They all had to be 18 years of age. They had to be available to participate in 8 treatments and 5 evaluations over a 6-week period. They couldn't have any previous ankle sprains or other similar foot ankle injuries in the past 12 months that were currently bothering them. And there had to be no contraindications to cryotherapy like Raynaud's, cold urticaria, etc. The study itself was a single-blinded, parallel group randomized trial where the evaluators were blinded to what the patients treatment was receiving. The 2 groups were the neurocryostimulation and then the ICE group. These were chosen by an independent researcher who was not involved in the study, and they were concealed in opaque envelopes and were given to the patients at their baseline evaluation. The standardized protocol for their treatment included 3 sessions per week for their first 2 weeks and a session per week for the next 2 weeks. These treatments all included some variations of stretching, exercises, soft tissue massage, joint mobilizations, and compression. And the type of cryotherapy delivered was at the end of their sessions. The 5 evaluations conducted were a baseline. They were done at weeks 1 and 2, the end of their treatments at week 4, and then week 6, so 2 weeks later. The outcome measures used were the functional capacity being the primary, using the lower extremity functional scale, using pain for the visual analog scale, ankle dorsiflexion range of motion using the weight-bearing lunge test, and then assessing edema using the figure 8 measurement.
So the main takeaway for our article is that neurocryostimulation was not more effective than ice, since using things like the LEFS, dorsiflexion range of motion, pain and swelling, the changes between them were not significant enough to say that NCS is superior than ice, although both groups did improve throughout the study. Difference between how cold neurocryostimulation makes the skin compared to traditional ice was not any translation into a better clinical improvement. It's most likely that the rehabilitation program was the biggest reason for such great results. So that's things like early mobilization, good exercise progressions, successfully bracing and healing short. The study had minimal missing data, and all of the participants completed all 8 treatment sessions.
All right, now I'll be reviewing the NCS protocol and comparing it to traditional ice application, like the ones we've done in class. With NCS, the technique involves slow sweeping motions using the cryotherapy gun, and each zone is treated only until the skin temperature reaches about 4 degrees Celsius, which takes about 20 to 30 seconds. The intervention is capped at 2 minutes, and because the cooling is so intense, post-treatment skin temperature can drop more than 23 degrees Celsius. That rapid cooling is followed by equally quick rewarming. In contrast, the traditional ice protocol we learned, 20 minutes of application with more gradual cooling produces a milder temperature change, but incorporates other additional benefits like compression and elevation. So even though the mechanisms differ, both interventions aim to reduce pain, limit swelling, and slow down tissue metabolism.
So as discussed, NCS did not outperform traditional ice with the criteria that it tested, and it was found that most of the improved outcomes came from exercises and not the biophysical agent that was used. And also, we concluded that considering the low cost of traditional ice, that traditional ice would be the superior agent to use for a lateral ankle sprain. And we suggested to further improve evidence that larger sample sizes should be used for NCS and that they should track outcomes through different grades of ankle sprains to see if neurocryostimulation would improve outcomes for a grade 1 more than a grade 3, and etc., and compare that with traditional ice. Thank you for watching. We have some references.